Thanks for the organizing committee for this opportunity to be with you today. And now to session number 7, Landscape of Management of Lung Cancer in 2020. This session is co-shared with the honor with Professor Mohammed Abdel Qadir and my dearest colleague, Professor Maya Izzeddin. Welcome, professors. Now I have the pleasure to introduce the first speaker in this session, Professor Robert Perker. The title of the talk is Metastatic Non-Small Cell Lung Cancer Without Driver Mutations. Please, Professor Robert.
Thank you very much. Good evening. It's my great honor to give a talk to Egyptian doctors this evening. And thank you once again, Ain Shams University, for this invitation. My first talk is on treatment of metastatic non-small cell lung cancer without driver mutations. Let's come to advance now.
Professor Perker, appreciate sharing your screen, please.
You can't? Oh, sorry. Video starten.
Yes, now we can see the video.
Can you see the video? Can you
Yes.
see the screen, the slide?
Not yet.
Can you see the slide?
Not yet. Only the video.
Okay, just a second. I have to go to Zoom. Can you see me?
Yes, we can see you, but we are waiting for you to share the
slides.
screen.
Yeah, I'm just.
There's a green icon, share screen. Is it working or?
No, it's not working. So that's what I can't find it. I had it on the screen
it's on
before.
the bottom of the screen, sir.
So on the bottom of the screen, in the middle, you can find.
Yeah, but I don't. The problem is. Can you see that? Can you see my video?
We can see your video, but we cannot see the screen yet.
Yeah, I don't know what the problem is because I don't see the screen where I can go.
You need to open the presentation, then press the share screen button.
Yeah, I have seen the share screen button before, but I don't have it now on my screen.
So maybe can you log out and log in again, please?
Yes, I log out and log in again. Yeah,
please.
I'll be happy to. I'm Abdul Jazi, Abdurrahman Jazi. I'll be happy to do my presentation if you would like me to get the space.
Okay, please do, sir. I think Professor Mohammed Abdel Qadir will present Professor Abdurrahman Jazia. Professor Mohammed Abdel Qadir, please.
It's okay, I can introduce myself.
No, it's okay, sir. Please, Professor Mohammed Abdel Qadir, are you there?
Yes. Yes.
Okay, I have the honor to introduce Professor Abdurrahman Jazia. He is chairman of the King Abdulaziz Medical City and professor at the King Saud bin Abdulaziz University. He is also an adjunct professor at Al Faisal University and also an advisor to the Oncology Quality Care and Patient Safety Program at the University of Cincinnati, Ohio, USA. And I hope I haven't forgotten anything, Professor Abdurrahman. Very impressive, really. And we're so glad to have you here.
Thank you, Dr. Prof. Azzuddin. It's a pleasure to be with you first, and I'd like to thank the organizing committee for inviting me. It's a pleasure to be with you. So I will talk about management of locally advanced non-small cell lung cancer. I will start with an overview of real-world evidence on the management of stage 3, and especially the lessons learned from the Kindle study, the role of adjuvant therapy, and then the role of consolidative immune therapy, and then I will touch into the standard of care guidelines. So I'm not going to go over the statistics of lung cancer, except to say that stage 3 forms about a third of the 2 million cases diagnosed with lung cancer, which is like 700,000 patients. It's a large number. It's more than many other cancers. And unfortunately, still the outcome is poor, with around a third or less of the patients survive 5 years. So the Kindle study actually is a multi-country, multi-center observational retrospective study to basically reveal the patient's characteristics, disease burden, the pattern of treatment, and so on. It was sponsored by AstraZeneca. In this study, we included patients who were diagnosed between January 1st, 2013 and December 31st, 2017. We collected clinical characteristics of the patients as well as the disease characteristics. And we collected a type of treatment that was given to the patients and, based on the line of treatment, first line, second line, third line. And that was the primary objective of the study, is basically to describe what did the patients get in the real world in the management of stage 3 non-small cell lung cancer. The secondary objectives were related to the patient's outcome, such as overall survival, based on the line of treatment and other endpoints. So this study was presented in ASCO, abstract 9043, and you see the co-authors there. Actually, there were 3,150 patients, so it's a huge number of patients. And if you look at the patients' characteristics, and I just want you to look at the numbers here of patients that we have from our region more than 1,000 patients, and from Asia, more 1,800, and Latin America 231 patients. The median age was 63, and if you look, male predominance was there, especially in our area. Majority were smokers or ex-smokers. Stage 3A was more common than 3B. Adenocarcinoma expectedly was the most common histopathology subtype. And performance status 1 was the most common performance status among the patients. 58% of the patients had performance status of 1. What was surprising to me, actually, that we identified 25 regimens that were used in the first line. When we were conducting the studies, I thought we were going to have 6, 7, 8 regimens. But when I saw 25 regimens, I was really surprised, and you can see the whole spectrum of kind of treatment was used in these countries. But the most common regimen was concurrent radiotherapy, followed by chemotherapy alone, then sequential chemotherapy, which is 10%, and after that was radiotherapy and surgery versus chemotherapy, plus chemotherapy. Now, coming to the survival outcome for the whole population, I highlighted the significant one for you, because the table is busy, and I'll try to focus on the significant one. So, for example, younger patients had, and we'll focus only on this column, the overall survival. This is the p-value. Younger patients did better. Female did better. Actually, people in in Asia and in Latin America than the Middle East and North Africa. Never smokers were better. Stage 3 expectedly better. 3A. Adenocarcinoma. The EGFR mutant patients did better, and then of course patients with performance status 0 were better. When you look at the survival by stage and the type of treatment, you find, for example, patients with the stage 3A who did surgery did significantly better than the rest of the group. But concurrent chemoradiotherapy still did very well, especially in the stage 3B. So now looking at the survival, multivariate analysis survival by stage 3A and 3B, and we highlight here the significant overall survival in the last column, if you see it. Again, younger than 65, ECOG performance status less than 2, Asia versus Middle East did better, female did better, adenocarcinoma. If patient had surgery first line, did better. Concurrent chemoradiotherapy also first line did better. And if they have trimodality in the first line, did generally better with actually significant p-value. When you look at the stage 3B, the age did not matter much. The ECOG performance status was significant. The better the performance status, the better the outcome. Asia also still did better in stage 3B than the Middle East. Adenocarcinoma, surgery versus no surgery also did better. I need you to keep in mind that this is not comparison. These are not randomized studies. This is real life. That means the patients who go surgery is selected subgroup, small number of patients. So we are not here trying to come up with guidelines. I'm just showing you what the real world data. So I don't want somebody to say, oh, surgery in stage 3B does good. No, it's not. Most of the time it's not indicated, but the group of patients. If you look at those who have surgery first line is 48 patients only. So it's we have to put these things in perspective. But I'm just sharing you the real world data, sharing with you the real world data. Progression-free survival, of course, 3A better than B. When you look at the overall survival, actually still, this is both the groups, the middle line. And when you look at the 5-year survival, we are still talking about 35% surviving 5 years. So, that reflects what we know about this disease, that, still having way to go in terms of enhancing the outcome of these patients. The lessons we learn from this is very critical to enhance the multidisciplinary function. So this has remained unmet need. And, we have to collaborate within the same institution as a multidisciplinary team, inter-institution, so we can, collaborate. If somebody has access to certain, intervention that the other institution doesn't, so they can refer to each other, collaborate and change experience, and then across countries. Of course, we have to educate each other about the best practices and then continue doing research. And especially in our area, actually, we have to do a lot of work in the Middle East, North Africa area. So this is the conclusion. I don't want to waste time. I noticed there is an adjuvant therapy talk by the prof, so I'm not going to take the thunder of his talk. I'm sorry, I will just go through the slides quickly then. So this is presentation by Dr. Roy Herbst. And then, the prof will talk about this, basically randomized patient from 1B to 3A, osimertinib versus placebo. And the patient characteristic, I will not go through the details, except you see 3A and 2B were 2 and 3A were the primary endpoint for the disease-free survival. You see significant p-value and impressive hazard ratio. When you include all the patients, And I just want you to see here that, again, that the higher the stage, the better the benefit. So here our locally advanced disease, when you look at it in this, you see the best hazard ratio is in stage 3A. Again, I'm not going to dwell on that. I will let the prof talk about it. So this is the curve showing better result in 3A. I will not talk about this one. Then basically they concluded that for resected patients who have EGFR mutation, osimertinib is now the standard of care, or this is practice changing, as they say. So I'm just trying to touch on the locally advanced disease. I don't know if the prof will cover this one, but basically, in ESMO they presented that patients who have osimertinib had much less recurrence, 11% versus 46%, and most of the recurrence were local recurrence in osimertinib, unlike the placebo. And 10-to-1, there was, those who did not have osimertinib, 10% have a brain mets versus 1% on osimertinib. So this is significant reduction in a very morbid recurrence. We all know how trouble is the CNS recurrence. So there was significant difference in the CNS disease-free survival, with the impressive hazard ratio that we don't see much, like this, So you are seeing hazard ratio between 12 and 20% in this osimertinib studies. I will stop about the adjuvant therapy, leave the more details and to the prof and then to the discussion. I will move on to the second practice changing study, which happened before the adjuvant treatment, and that is the consolidation by immune therapy for unresected stage 3 lung cancer who received chemoradiotherapy. This we may have to talk a little about it in some more details. So if the study was a specific study, we all know about it, that included patients with stage 3 that were unresectable, that received concurrent chemoradiotherapy, platinum-based, and they were stratified by age, sex, and smoking history. They randomized 2-to-1, 713 patients. 2 received durvalumab, 1 placebo. The durvalumab was 10 milligram per kg every 2 weeks for 12 months. So the duration is 12 months. The osimertinib was 3 years, by the way, as adjuvant. So the primary endpoint was progression-free survival by blinded independent central review committee and overall survival. And there are a whole host of secondary endpoints. Basically, the patient's characteristics generally are balanced. Is no major issue. So even if there is one, something about the BDL1, we'll touch upon the result. So even if there was some difference in the number, but that did not make a big difference in the end. So in the progression-free survival, there was 49% reduction in the risk of progression. So you see how the curves are nicely separated early on. Probably this is from the first assessment, and then they are separated. And if you look at these cutoff point that they have them in the secondary ongoing survival at 12 months, at 18 months, you see that the hazard ratio was 50%, 0.51, and you look at the actual percentage in difference, 49, almost 50% versus 26%. And so on. So there is significant difference in the progression-free survival. You see also there is, almost all the subgroups in this forest plot, all the subgroups almost benefited from it. There is the EGFR mutant patients did not benefit from that, you know, but probably the elderly on the margin here. But majority of the subgroup did benefit from this. Now, highlighting the PD-L1C, or irrespective of the PD-L1, all groups benefited. So you do not, as a standard of care, you do not need PD-L1 testing to use durvalumab. So to settle that issue, even if other countries requested it, could be for economical reason, could be whatever, it doesn't matter, but it is not based on evidence. Evidence here for consolidation therapy, you don't need PD-L1 for stage 3 lung cancer. Now, the 3-year survival, I did not want to show you too many slides about the 2 years. So this is the most recent slide, and this is very, continue to be impressive difference. So you see here, you know, the median overall survival was not reached versus 29 months. And you see in each time, in each cutoff, there is significant difference, 11%, 11%, 11%, with a hazard ratio of 0.69. You know, so this is very positive result all the way with the 2 primary endpoints. So you see them, the number I highlighted for you. So there's 31% reduction in the risk of death by using durvalumab in this setting. So I don't want also to read this. Basically, it's clearly that there is a benefit for durvalumab in the setting of patients who received chemoradiotherapy. And the very important point here that I should have highlighted in the inclusion criteria, that the patient should be enrolled in the study within 42 days, 7 weeks, and the earlier the better. So the sooner you can get your patients on the durvalumab, the better. So now moving to the guideline, I don't want to go over too much guideline, and I'd like to ask people to visit this link, either this link or the QR. And basically you can download the management of stage 3 non-small cell lung cancer guideline, which was published last month, a couple of months ago by our group. Actually, we have a multidisciplinary lung cancer consortium with the Saudi Lung Cancer Association. So this is up-to-date stage 3 management guideline. You can go through it. I would just focus on this graph here to explain to you what is needed, and I will stop there for the sake of time. There is, when you confirm stage 3, present in tumor board. Then discuss if the patient's surgical candidate. If surgical candidate, that does not mean you have to do surgery up front, but you may have to take him through fast track of assessment and see if they'll benefit from surgery. If it's not a candidate for surgery, you do concurrent chemoradiotherapy, and then quickly they go to durvalumab. You don't want to wait too much from the beginning. If the surgeon tells you he's not surgical candidate of the team, not the surgeon, said he is not a surgical candidate, you don't have to wait. So you do chemoradio, right away you switch to durvalumab and move on, okay, for 1 year. Now, if they said, yes, he's potentially surgical candidate, you do concurrent chemoradiotherapy, you assess response. If it's resectable, you resect him. And if it's not resectable, you go to durvalumab. So this is if disease progression. So here, sorry, this is not clear. If there's disease progression, no disease progression, you go to durvalumab. If there is disease progression, you switch to chemotherapy. And then if the patient undergoes surgery, whether it's after concurrent chemoradiotherapy or for whatever reason use neoadjuvant, or for whatever reason patients undergo to surgery right away, you have to check EGFR. And then if EGFR is mutant, you give osimertinib for 3 years. If it's not mutant, you give adjuvant chemotherapy, 4 cycles of chemotherapy. So this is very important. When you give concurrent chemotherapy, if it's stable, not resectable, you take him to durvalumab. Progressive, you take him to chemotherapy, and then you go from there. And I will stop here actually, for the sake of time. And if there's anything about I think the concurrent chemo, radio, and all the type of chemo used and so on, it should be a clear standard. There's no need to rehash it again. But I'll be happy to, if we have, to show you slides in regard to that if we need to talk about it. I will stop here, and I'll be happy to take questions in the question and answer session. Thank you. You are muted, Prof.
Thank you so much, Professor Abdulrahman Jazia, for this very informative lecture. And I don't know if we have any questions in the chat box, or if anybody would like to ask any questions, please do in the Q&A section. Otherwise, I would have to postpone your questions to the end of the session. We'd like to now present Professor Robert Perker. Professor Perker, is the presentation okay now? Can you hear me, sir?
Yeah, I can hear you, but I lost now this full screen again.
Oh, okay. Anyway, I'd like to...
I get it now. I get it now. I need my slides.
I'm always glad to see you, and we're glad that everybody's still standing in there. Tough. It's been a long day, and I'm happy to co-host with Professor Muhammad Abdelader and Professor Sharif Abdulwahab.
Professor Perker, we have your slides. If you have any difficulty, we can play it from here.
I have the adjuvant slides ready. I should have both of them ready, but I start. What should I start with, adjuvant or metastatic?
Okay, as you like.
Okay, can you put the metastatic slides up? I have it here. Yes. Put it on. So, first of all, thank you very much. I do apologize for this inconvenience. Let's come to treatment of metastatic non-small cell lung cancer. Can I forward the slides? So we have chemotherapy at least for about nearly 30 years available as standard chemotherapy with platinum-based doublets with a third generation drug. We have a clear benefit for the patients in terms of symptom relief. We have an improvement in 1-year survival rates and potentially also improvement of quality of life. But there are several factors that affect outcome, performance status. Also, age plays a major role, but also elderly patients and patients with poor performance status benefit from palliative chemotherapy. So palliative chemotherapy with the platinum-based doublet for all the patients with good performance status, or if you have a poor performance status, or if you're elderly, you can consider well-tolerated doublets, for example, carboplatin-based doublets, or a single agent. In patients with non-squamous non-small cell lung cancer, we have the option to combine chemotherapy with bevacizumab. In non-squamous, you have a benefit if you combine it with carboplatin paclitaxel in terms of overall survival. We didn't see a benefit in terms of overall survival in the AVAIL trial. So at least in Europe, there was a discussion about the role of bevacizumab if you give chemotherapy with the cisplatin-based protocol. But nevertheless, carboplatin plus paclitaxel combined with bevacizumab is superior to chemotherapy alone. Next slide. In patients with squamous cell non-small cell lung cancer, we have the option to combine chemotherapy cisplatin plus gemcitabine with an anti-EGFR monoclonal antibody necitumumab based on this trial with a survival benefit. So we have chemotherapy plus minus bevacizumab in non-squamous or plus minus necitumumab in squamous cell non-small cell lung cancer. Next slide, please. So what other options we have? We have maintenance therapy, pemetrexed is well established. And then in patients who progress after first-line treatment, we have several options. We have docetaxel, pemetrexed in non-squamous, we had erlotinib, we had afatinib in squamous, and we had docetaxel in combination with nintedanib in non-squamous cell non-small cell lung cancer, or docetaxel plus ramucirumab in the REVEL trial. So we have several options, and usually in non-squamous cell non-small cell lung cancer, many doctors treated with pemetrexed containing protocols. So at the time of disease progression, patients were receiving docetaxel, more recently in combination with nintedanib, and in case of ramucirumab, you can treat docetaxel plus ramucirumab independent of histology. So that's what was available for the last, let's say, 10 years. What has changed completely is the fact that we moved from chemotherapy to chemoimmunotherapy. We have the immune checkpoint inhibitors, we have anti-PD-1, anti-PD-L1. We have nivolumab, pembrolizumab, semiplimumab, and we have atezolizumab, durvalumab, and avelumab. And of course, we have other drugs available. And then we have also the anti-CTLA-4 antibodies, ipilimumab, tremelimumab. And the clinical development first was in patients who progressed after first-line chemotherapy, either as single agents or in combinations. And then, of course, the focus was on combination tree on immune checkpoint inhibitors in the first-line setting, trials with single agents, particularly in patients with high PD-L1 expression. And then we have, of course, the major trials, chemo, immunotherapy, immune checkpoint inhibitor, plus a platinum-based tablet. This trial just summarizes the major trials in pre-treated patients, immune checkpoint inhibitors versus docetaxel. And we have three drugs. We have nivolumab, pembrolizumab, and we have atezolizumab. All these three drugs, when given as single agent, have resulted in superior overall survival. And all of these three drugs have been approved for treatment of patients who progress after first-line chemotherapy. So that's in pre-treated patients. But the focus, of course, was then to go into the first-line setting. And in the first-line setting, next slide, initially the trials were done in patients with high PD-L1 expression. We had the KEYNOTE-24 trial, pembrolizumab versus chemotherapy in patients with PD-L1 expression in 50% or more of the tumor cells. And what you can see, you have a nice improvement in overall survival. I usually take the hazard ratio. So you have a 40% risk reduction in favor of pembrolizumab over first-line chemotherapy in case of high PD-L1 expression. These results were confirmed in the KEYNOTE-42 trial, where they included also patients with lower expression levels, but the benefit in all these trials, although it was positive for greater 1%, greater 20%, and greater 50%, the benefit in all these groups were driven by patients with high PD-L1 expression, because there was no significant improvement in patients with PD-L1 levels 1 to 49%. And then we have also the trial with atezolizumab, a similar outcome, superiority of the single agent over chemotherapy in high PD-L1 expressors. And most recently, we had also a trial with semiplimumab, which also has resulted in a survival benefit. So in patients with high PD-L1 expression, you have the treatment option of single agent pembrolizumab, single agent atezolizumab, and in the future also of semiplimumab. And if you see the hazard ratios, it's about a 30 to 40% risk reduction. So that's for patients with high PD-L1 expression. In the next slide, you can see the major trials in non-squamous cell non-small cell lung cancer, chemoimmunotherapy, chemotherapy plus an immune checkpoint inhibitor. We have trials with pembro, with atezolizumab, and all these trials have shown a PFS benefit and also a survival benefit in favor of chemoimmunotherapy over chemotherapy. So, and the hazard ratio, for example, with pembro plus chemo was 0.49, so approximately 50% risk reduction in terms of deaths. The hazard ratio was slightly higher in the other trials with atezolizumab. But nevertheless, you have now pembro in combination with chemo, you have atezolizumab in combination with chemo plus bevacizumab, but you have also the option of atezolizumab in combination with carbo plus nab-paclitaxel. So this trials resulted in a movement from chemotherapy to chemoimmunotherapy in patients with advanced non-squamous cell non-small cell lung cancer. The next slide just shows you an update on the Keynote 189 trial, chemo plus pembrolizumab. It's the overall survival final analysis, hazard ratio 0.56. The next slide shows you the results, the final analysis of the IMpower 150 trial. It was a more complex trial, carboplatin plus paclitaxel plus minus bevacizumab plus minus atezolizumab. The main take-home message was that in this trial, if you add atezolizumab to bevo plus carbo plus paclitaxel, you have a significant survival benefit with the hazard ratio of 0.76. If you give just chemo or you replace bevacizumab only with atezolizumab, there was of course also a difference in favor of atezolizumab. However, the trial did not meet statistical significance. So in this, the take-home message is here, if you use carbo plus paclitaxel plus bevacizumab, a typical American chemotherapy protocol, if you add atezolizumab, you further improve overall survival. So we have atezolizumab and we have pembrolizumab in combination with chemotherapy in the first-line setting. The next slide shows you two major trials, two major phase 3 trials in squamous cell non-small cell lung cancer. Keynote 407 and IMpower 131. So chemo plus pembrolizumab or chemo plus atezolizumab versus chemo alone. And what you can see here, it is the hazard ratio there's a significant improvement in terms of progression-free survival in favor of chemoimmunotherapy. There's also a survival benefit for chemo plus pembrolizumab. There's no significant survival benefit demonstrated in the IMpower 131 trial, but PFS, of course, was significant benefit. So once again, also in patients with squamous cell non-small cell lung cancer, you now treat with chemo plus an immune checkpoint inhibitor such as pembrolizumab or atezolizumab. Other trials, next slide, please, focused on double immune checkpoint blockade. Nivolumab plus ipilimumab versus platinum-based doublet chemotherapy in the Checkmate 227 trial was a formal positive trial where you demonstrated a survival benefit for the double immune checkpoint blockade with nivolumab plus ipilimumab over platinum-based chemotherapy. And the MYSTIC trial, there was no significant benefit in terms of progression-free survival, whatever the reason is when you have durvalumab plus tremelimumab versus platinum-based doublet chemotherapy. The survival also was not significantly different. So the take-home message from these trials is that nivolumab plus ipilimumab is a treatment option in patients with advanced non-small cell lung cancer. Next slide. This is the Checkmate 227 trial. The publication recently in the New England Journal of Medicine, nivolumab plus ipilimumab versus platinum-based doublet chemotherapy in PD-L1 positive patients, which was one of the primary endpoints, and a significant improvement. So it's a treatment option with a hazard ratio of in the range of roughly 0.8. Next slide, please. Another trial recently presented or published was the combined immunoblockade durvalumab plus minus tremelimumab as third-line or later treatment of metastatic non-small cell lung cancer. If you go to durvalumab, you have a significant improvement of durvalumab over standard of care. The difference is also there for the combined treatment, but it was not statistically significant. So it seems to be a treatment option in the future also in pre-treated patient, heavily pre-treated patient as a third-line treatment, durvalumab plus tremelimumab or durvalumab. Next slide. Here I just summarized my treatment options. Now here for the non-squamous cell, non-small cell lung cancer driver negative, you have several options. Of course, the preferred treatment, which is shown in bold, is chemo plus pembrolizumab or chemo plus bevacizumab plus atezolizumab or chemo with carbo plus nab-paclitaxel plus atezolizumab. Of course, you can also give nivolumab plus ipilimumab. If you don't have access to first-line treatment with an immune checkpoint inhibitor, you still can treat with platinum-based doublet, but then you should make sure that at least at the time of disease progression, patients get an immune checkpoint inhibitors. Other patients who get chemoimmunotherapy in the first-line setting are then candidates for docetaxel plus minus nintedanib or plus minus ramucirumab. Then you have also the third-line treatment options. If you have high PD-L1 levels, you can treat with a single agent. I prefer first-line treatment in high expressors also with chemo plus immune checkpoint inhibitors. But I know that at least my feeling is that American doctors still prefer the single agent with the argument that's better tolerated. And then you have also the option of atezolizumab. The next slide shows this gives us just a summary for the squamous cell non-small cell lung cancer. And once again, you have options chemoimmunotherapy with pembro atezolizumab. You have the option of dual blockade with nivo plus ipilimumab. And then you have other treatment options as mentioned before. Patients with high EGF expression still are candidates for platinum-based chemo with gemcitabine plus nab-paclitaxel. So this is my treatment suggestion. And at the end, I just show you a slide of a patient which I treated very early on. Next slide. This was a male heavy former smoker, and the squamous cell non-small cell lung cancer has stage 4 disease. He had adrenal gland metastasis. He had multiple metastases also in the liver, which I don't show here. So we started to treat with nivolumab. Next slide. You just see that treatment with nivolumab, single agent in a high expressor, there was a significant improvement in the primary tumor in the lung. Next slide. There was also improvement at a decrease in the size of a metastasis to the adrenal gland in the right side. So this patient was treated with nivolumab as part of the checkmate trial. Finally, this trial did not show the superiority of nivolumab over platinum-based chemotherapy, but the outcome was similar. So of course you have efficacy also for single agent nivolumab, but nowadays I would treat this patient in a combination of chemo plus immune checkpoint inhibitors. So I think the major advance has been the movement from chemo to chemoimmunotherapy. Thank you very much. Don't forget, don't smoke. That's what we know, everybody. But I think that's very important.
Thank you. Thank you, Professor Becker, for this elegant and nice presentation. And now you go to the second presentation for Professor Becker.
I think I can manage this. I can manage this myself.
Okay, go.
Can you see?
Yes, sir.
Yes. So adjuvant therapy in resected non-small cell lung cancer. When I talk about treatment of lung cancer, one of my preferred talks is adjuvant treatment, because over my last 30 or nearly 40 years in medical practice, I think I would consider this as the major advance in the management of non-small cell lung cancer, because you could increase the cure rate. That's why I think it's very important. So in the early 90s, 1995, there was a major meta-analysis on the effect of chemotherapy in patients with non-small cell lung cancer. And this meta-analysis also included adjuvant chemotherapy. And what it suggested that adjuvant chemotherapy with a cisplatin-based doublet, or not, or put it another way, with cisplatin-based chemotherapy, shows a trend towards improvement of overall survival, and the gain at 5 years was approximately 5%. The hazard ratio was 0.08, so it was just a trend and not significant. But this positive sign, this trend in favor of chemotherapy after complete resection of non-small cell lung cancer, led to several major phase 3 trials. I just refer here to the 3 positive trials, YALC, JBR10, ANITA. And what the trials demonstrated that you can increase the 5-year survival rate by approximately 4 to 15% based on the trial. It was 4% in the YALC trial, which was the largest trial. I participated in the YALC trial. And it was 15% in JBR10 trial, and it was about 9% in the ANITA trial. Then again, a LACE meta-analysis, a meta-analysis of all the phase 3 trials that included the 3 positive trials and also negative trials, such as this the big lung trial and the ALTC trial. And this meta-analysis confirmed the improvement in the 5-year survival rate, and the gain according to this meta-analysis was 5.4%, hazard ratio 0.89 in favor of adjuvant chemo. And based on this, and particularly since the publication of the YALC trial, adjuvant chemotherapy was increasingly used in clinical practice and is now standard treatment. The question is, which type of chemotherapy? Okay, can you hear me?
Yes, we can hear you. Yes, Professor. Yeah, go ahead.
Go ahead, sir. Here? Professor.
Can you hear me?
Okay, we hear you.
Yes, let's go to LACE mineral meta-analysis. So the JBR10 and the ANITA trial had cisplatin plus vinorelbine as chemotherapy, and 76%, 27% of the YALC trial had also cisplatin plus vinorelbine as chemotherapy. When you use this chemotherapy protocols, cisplatin plus vinorelbine, the hazard ratio is 0.8, and the 5-year survival gain is 8.9%. That's how I explain this to my patients. That's here in the slide shows you not the LACE meta-analysis, the subgroup analysis of LACE based on chemo with cisplatin plus vinorelbine. So the 5-year survival improvement is 8.9%. And you see also an improvement in the stages, and the improvement is of course greater in the stage 3 than in stage 2. And there's no improvement in stage 1. And based on this, I explain my patients the benefit you gain about 10% by giving 4 cycles of adjuvant chemotherapy. And I usually stick to cisplatin plus vinorelbine. I know that other people give other chemotherapy, but we can have a discussion later on. So what is the status of adjuvant chemo? All patients with stage 2 and 3, and based on this 6DNM classification of selected 1B candidates, of course, they have to have good performance status, they have adequate organ functions, rapid post-operative recovery, and I inform them about the benefits. So they know the gain will be approximately 10% in survival at 5 years. And I treat usually with cisplatin-based chemo, and usually I treat with cisplatin plus vinorelbine, except if the patient is at risk, for example, of neurotoxicity. I begin 4 to 8 weeks after surgery. And what's also important is support for smoking cessation. If the patient does not tolerate cisplatin-based chemotherapy, I give no chemotherapy. So what are the strategies to improve outcome? Of course, you could optimize chemotherapy. An interesting study was recently presented by the Japanese group, ASU-ICOC 2019. And what they wanted to show that the chemo with cisplatin plus pemetrexed is superior to cisplatin vinorelbine. And the trial failed to show to demonstrate an improvement in progression-free and relapse-free survival, and also in overall survival. So the trial was negative. So the trial did not demonstrate the superiority of cisplatin plus pemetrexed over cisplatin plus vinorelbine. So now you can discuss this. You can say the curves look similar, but you have a very strict, you cannot say this outcome is non-inferior or similar, because the aim was to show superiority and that was not met. So it's an interesting thing how you interpret these results. So what are our strategies? We were very much involved in predictive biomarkers. We initiated Yalt Bio, and which ended up in Lace Bio together with French doctors, Dr. Le Chevalier and Dr. Soria and Fabrice André. Take-home message: there is no predictive biomarker available, so predictive biomarkers remain experimental. Customized chemotherapy remains experimental, so the strategy is to integrate targeted therapies, but it's not so easy. Bevacizumab added to chemotherapy failed. This was the large ASU-ICOC trial, so no improvement by adding bevacizumab to adjuvant cisplatin-based chemotherapy. What about patients in who have mutation-positive disease? There has been a major recent advance, because there were phase 3 trials in patients with resected EGFR mutation-positive non-small cell lung cancer. We have a Chinese trial, we have the Aurora trial, and we have a Japanese trial ongoing, the Alchemist trial. Let's first come to the advanced Chinese trial. So it was comparing adjuvant treatment with gefitinib to adjuvant treatment with cisplatin plus vinorelbine. What you can see here, there's a significant improvement in progression-free survival for gefitinib over chemo for patients with resected mutation-positive non-small cell lung cancer. What about overall survival? Overall survival, as recently presented by Dr. Wu, is not different. So there's no difference in overall survival. So the big issue always comes up: what is the main endpoint, or what is the most clinically relevant endpoint in the adjuvant setting? So I usually argue it has to be overall survival, but some people might say, particularly have a great improvement in the progression-free survival, it might be also clinically meaningful. So this is the Chinese trial. What changed also now recently was that don't use a first-generation TKI, but use a third-generation TKI osimertinib. And this was a well-conducted study, Aurora, because patients had to have stage 1B to 3A completely resected non-small cell lung cancer, and they were eligible to receive adjuvant chemotherapy. So I think this is an important thing, that they receive standard treatment, surgery followed by adjuvant chemotherapy, if they were eligible. And then they were randomized into osimertinib or placebo. And what the result clearly demonstrates is a huge difference in disease-free survival in patients with stage 2 and 3A disease. Hazard ratio 0.17. So it's a 83% risk reduction in death. So even if there's no survival benefit, yes, I would argue this is such a huge difference in disease-free survival that I would accept disease-free survival as a clinically meaningful endpoint in this disease stage, and would say that patients with EGFR mutation-positive disease should receive adjuvant chemotherapy followed by adjuvant treatment with osimertinib. And we will see what the impact will be on overall survival, but this is, of course, very preliminary. Another trial is still ongoing, similar design, Alchemist trial, is with EGFR mutation-positive or ALK positive. They're randomized then to erlotinib or placebo, or crizotinib or placebo. And what's also important, patients are allowed to receive adjuvant chemotherapy. So we will see what's happening here. But whatever the benefit will be, you have this huge benefit by osimertinib. And I'm not sure whether this benefit will also be seen with the first generation TKI such as erlotinib, but we will see. What else is ongoing? Immunotherapy. Another major trial failed, MHS3. This was a huge, the largest adjuvant trial. They screened more than 10,000 patients for the presence of the MHS3 vaccine, and it was a negative trial. And that's why I was so very, over all the years, I was very negative about immunotherapy, but I had to change my negative attitudes based on immune checkpoint inhibitors that have shown clearly benefit in the palliative setting, stage 4, but also, as mentioned before, as in consolidation therapy in patients with stage 3 disease after chemoradiotherapy. So the main trials are now ongoing with immune checkpoint as adjuvant treatment. So what are the advantages? Of course, they are efficacious in advanced non-small. They are efficacious as consolidation therapy, but it's very likely that they might improve outcome also in the adjuvant setting. And we need new adjuvant treatments. And another advantage the adjuvant setting could be that we have a low tumor burden and the patients are fit. So I think these are some advantages for this immune checkpoint in the adjuvant setting. There are challenges, however. It's not so easy to increase cure rates. The long-term toxicity is unclear. The question is also, is a single agent or combined with chemotherapy? Most trials have single agent after adjuvant chemotherapy. I probably would consider starting with chemoimmunotherapy followed by single agent treatment. One of the questions is, of course, patient compliance. How will patient accept treatment every 2 or 3 weeks for 1 year? I'm not sure. And then, of course, it comes up to costs. So the benefit has to be quite big in order to justify the high costs of this treatment. So what trials are actually ongoing? I have summarized here 4 trials. I'm not sure that other trials are ongoing. And that's what I could find out of the trials, the number of patients. But sometimes patient trials are changing over time. Then the endpoints might be changed. The number of patients might be changed. But nevertheless, we have trials with nivolumab, Envil. We have pembrolizumab, PERS. We have adjuvant PR31, durvalumab. And we have the IMpower 10 trial with atezolizumab. All the trials give immune checkpoint inhibitors for 1 year as single agent versus placebo or versus observation. And interestingly, at the tumor stages, of course, they're clear. 1B, more than 4 centimeters, 3A. So it's pretty much what you would include patients completely resected tumors. The question is primary endpoint. Some trials have disease-free survival, and only one trial has overall survival and disease-free survival. So it comes up on the magnitude of the benefit. If the benefit in disease-free survival is huge, for example, as it has been shown for osimertinib, I would say disease-free survival is an acceptable endpoint. But if the benefit is only small, let's say a hazard ratio 0.8, I'm not so sure, and no proven survival benefit. So I would like to see also in the adjuvant setting, not only disease-free survival, but also the improvement in overall survival. So let's just summarize. Sorry, I have 1 slide in the adjuvant setting. Of course, large sample sizes are required because of the moderate benefit. It takes quite long time and it's costly. And of course, the selection of drugs is based on efficacy in the adjuvant setting. The question comes up, could there be different efficacies between the palliative setting and the curative setting? I don't know. As I mentioned, what's the most appropriate endpoint? I would like at least see some data on overall survival, if not overall survival is the endpoint, but I would go for overall survival as the endpoint. Then there's the question, novel trial designs. Of course, focus on patients with high risk of recurrence. That means you need fewer patients. Then the question is, do we have surrogate endpoints for survival? The question is disease-free survival as a good surrogate endpoint for overall survival. And another interesting disease is, or that is argued, that you don't take, let's say, a time endpoints, but you take, for example, residual disease assessed by circulated tumor DNA after treatment. But first, before you use this as an endpoint, you have to show that residual disease is a surrogate endpoint for overall survival. So you have first to prove it. So there are strategies, but at the moment, they are not have not entered clinical trials, in particular not phase 3 trials. So phase 3 trials have disease-free survival and overall survival as primary endpoint, and have the typical phase 3 design. To summarize, we have adjuvant chemotherapy as a major advance. Predictive biomarkers and customized chemotherapy remain experimental. Several trials failed, bevacizumab, EGFR TKIs in unselected patients or in non-mutated patients. Margaret, the MHA3 vaccine failed. But among patients with EGF mutation positive disease, we have osimertinib and gefitinib with positivity in phase 3 trials, disease-free survival improvement. I would say osimertinib is the treatment of choice for these patients nowadays. And we have interesting phase 3 trials ongoing with immune checkpoint inhibitors, nivolumab, pembrolizumab, durvalumab, and atezolizumab. I was asked to show you a slide on adjuvant chemotherapy. I have one of my radiologists provided me with this interesting case. I have taken this case. I will tell you why I have taken this case. So you see a tumor on the left side. It's a 2.2 centimeter lobulated solid nodule in the lingula. If it's lobulated, it is more likely to be malignant. And then you see a 3.6 centimeter part solid mass in the right upper lobe with a ground glass opacity halo or the glass halo. And you have also the PET CT scan. And what you see in the PET, there's no uptake except in the 2 lesions. So the question comes up, are these 2 primary tumors or is this metastatic disease? My take-home message is this, and I've seen this, as I would go as long as this is resectable and the patient is operable, go for surgery and don't take this as a stage 4 disease because of a contralateral disease. I have seen this, that these things like this happen. They take out one tumor on one side, it's malignant, and they take the other side as a malignant disease, as a metastasis. And that's taken as stage 4 disease and withhold curative treatment. So I think you have to be very careful if you have 2 lesions. That's the possibility. These are 2 primary lesions, and this is probably more likely than a metastatic disease, particularly if we don't have any mediastinal lymph nodes. So that's what I take home, make sure that don't withhold surgery. And if it's a greater problem to withhold surgery in a curative setting, then give surgery in a palliative setting, because in a curative setting, the patient can lose his life. And this patient underwent surgery, and interestingly, he had different histologies. On the left side, it was a squamous, and on the right side, it was an adenocarcinoma. So this is just a slide. And here I have a family smoker, 70 years old. You could argue the tumor was only 3 centimeter. Probably, I would argue for no adjuvant chemotherapy, because the tumors, there are 2 primary tumors. The tumors were smaller, but not more than 4 centimeters. So the patient is 70 years. That's already an issue. Whether patients, because in the meta-analysis, elderly patients appear not to benefit. Of course, performance status is an issue. Somebody says, I want to give this female smoker adjuvant chemotherapy, it's fine with me. So it depends also what the patient wants, but probably if the patient is not very optimistic about chemo, I would not argue to go for adjuvant chemotherapy. So I would like to thank you very much. I do apologize for this mishandling at the beginning, and I wish you all the best. Hope to see you soon, because nowadays we just to see each other via the web conferences, and the net conferences are nice, but I think it's much more interesting to meet each other in person. So I hope that that coronavirus will go away. It won't be easy. We have now increasing cases again. And I don't know what the situation exactly is in Egypt. I was in Egypt in February. So I think there were the first cases there. But we still have We have, I think Egypt has 90 million people. I'm not 100% sure. We have 9 million people. So we have 1/10 of your population approximately, and we are roughly 800 patients daily, newly diagnosed. So thank you very much, and all the best.
Professor Sharif.
Professor Mohammed, please. Sound, Professor Mohammed.
Thank you so much, Professor Perker. It's always a pleasure to see you virtually or in real life, really. And I'd like to thank you and Professor Jazia for your very concise and informative lectures. And it's a very interesting case because I just saw a case recently also, but also 70 years old with bilateral and no mediastinal disease. So it was quite interesting. I just had a quick question, sir. What do you think about the latest update from the ESMO about the lack of adjuvant radiotherapy? The trial that it does not no longer endorses post-operative radiotherapy in mediastinal disease. Do you think it will be practice changing?
Is the question to me?
Yes, sir. Yeah, or to Professor Abdurrahman Jazia.
Yeah, we didn't give adjuvant. What we didn't give adjuvant radiotherapy in stages 1 and 2. We did give it in stage 3 disease in selected patients. That's how we did it as long, but it might change.
So adjuvant radiation therapy was never part of our recommendations at all. Yes. Okay. So because there was no evidence for its benefit for a long time, so we did not use adjuvant radiation therapy.
Yeah, I understand, but I was referring to stage 3.
Yeah. Even in stage 3, if it's completely resected, so we give adjuvant chemotherapy, not radiation therapy. Yeah, not radiation.
Okay, so it was not part of the practice anyway.
No. Although many, when they did survey, many oncologists, many practitioners, up to 70-80% of people used to give adjuvant radiation therapy. But that was not based on strong evidence. And the board for N1 was shown to be detrimental in the past. In this now in this ESMO, even N2 port was also not beneficial.
Yeah, that's true. But we never gave it in stage 1 or 2. But in stage 3, we gave it. Then we didn't give it. Then again, we gave it. So recently, we were giving it. So it's going in waves. But based on this, it will change again.
Yes. I'm not sure if Professor Sharif and Professor Mohammed Abdel Eder would like to have any questions or.
I think no more question.
Would you like to close the session, sir? Or?
I think no more questions.
Okay.
Is one question in the question room, please?
Yeah, there's a question about the positive margin. Would you give RT or just adjuvant chemotherapy? So what do you do, Prof Perker? What do you do?
If it's incomplete resection, we would give adjuvant radiotherapy, and we will give adjuvant chemo followed by adjuvant radiotherapy.
Okay, so I can go through. Yeah, that's good. So whenever there's positive margin, you really need to go back and talk to the team again. The recommendation, although this is not practical most of the time, is re-resection. Whenever you can do re-resection, you re-resect it. And however, if you cannot resect it for whatever reason, I would treat it like 3B. There's tumor cells there. I will give concurrent chemoradiotherapy. Yeah. So, but some people give radiation therapy alone. Some people give chemotherapy alone. I think I'm treating it like unresectable cancer is persistent there. It's like unresectable cancer. So, of course, there is no randomized study. This is just a matter of extrapolating from unresectable lung cancer. There are cancer cells that, you know, the best way to deal with it is to give concurrent chemoradiation. And of course, you have to take it based on the individual patients. You know, if patient cannot handle concurrent chemo and you give him sequential or give him just one modality, that's fine. If I'm going to choose one modality, probably radiation would be, but you know, it would be the preferred in case, you know, but the concurrent chemoradiation is my preferred approach if we can.
I wanted to also have a comment about the side effects, since we're starting to use immuno, of course, more in lung cancer. What about now we're also in the era of COVID-19? What about the crosstalk or crossfire about the side effects with patients on immunotherapy and the adverse events that we would see with the lung? Is it something that we should step back from using these agents in these times, challenging times?
We need more data, but I would argue I would still treat even in COVID according what we would treat. Of course, if a COVID infection, I would not give adjuvant chemotherapy. So if, for example, this in the palliative setting, you have first to treat the infection before you go for chemoimmunotherapy.
Yeah. So if the patient does not have infection, well, anyway, the Trevolt study and others did not show that immune therapy is compromising. Probably chemotherapy may have an impact. What I would do, I would probably try to use the less frequent regimen, I mean dosing. So for example, I could switch to every 6 weeks or every 4 of Bimbro or every 4 weeks of Nivo, just to make sure that we decrease the visitation to the healthcare facility. But I would not hold off treatment. You know, it's now we are embracing for a bigger avalanche of patients who were postponed the treatment for whatever reason, either by patient's choice not coming, being scared to come to the facility, or skipping treatment because of precautionary measures from the institution. I think now, and this may drag for 2 years, I think now we should try to treat our patients as normal as possible, but, you know, weigh the risk on individual basis. For example, I would not say I would not give adjuvant therapy totally. It depends on the adjuvant therapy. For example, if it's EGFR positive, you know, I would give TKI without any hesitation. So I will not hold any targeted therapy for lung cancer patients under any circumstances. You know, and probably only if they have active COVID-19. Even in that setting, I have to think about it, because it doesn't, unless you are doubting that is going to cause some kind of causing some kind of respiratory issue. Target therapy is not to be held.
Thank you so much, sir, for your answers.
Welcome.